Hello, students, HCM 830. This is Dr. D. Wanted to take a minute as we start Module 3 to give an overview on Chapter 18. There's a couple of chapters for reading this week, but I thought Chapter 18 was worthy of a deeper dive. It does talk about some issues that aren't necessarily mechanical economic issues, but they are issues that involve policy, technology, um, consumer provider consumer interactions that ultimately affect economics. So we'll go over that in a second. But what I wanted to do first is talk a little bit about what that live session will look like on the 28th. Technically, it's supposed to be a defense of your dissertation. However, I understand that some of you may not be at that point yet, and that's perfectly okay. And so you can feel free to take that time to do a presentation on wherever you are as it relates to your dissertation. So if you just want to give some background information and an overview on your review of literature, that's fine. For some of you that are a little more further along, and you want to give a formal dissertation, then that's fine too. But a lot of flexibility in the live session for the 28th. For those of you that have not already emailed me, letting me know your preference to either defend in the live session or do a pre-recording, please let me know. I do plan to publish the final list on Wednesday, which is a couple of days from now. Okay, so let's get right into Chapter 18. And these are some evolving issues in healthcare. Keep in mind from our live session a little less than a week ago, I believe, we talked about how textbooks they are scholarly sources, they are academic sources, but they aren't always accurate. Remember, even the best textbook takes anywhere from 18 months to 2 years to get published. And so I want you to understand that as you read your textbooks or as you decide which sources will be the premium sources that you'll use for your dissertation and your scholarly work in this course and into the future, even postdoctorate, right? I want you to look to get your sources directly from government websites, directly from educational websites, and even from peer review articles. Peer review articles tend to have a smaller publishing timeline than textbooks do, but those three are going to be your sources that you want to use for immediate information. Usually the information you find in a textbook is going to be anywhere from 3 to 5 years old, even if the textbook is published in the same year that you purchased it. So something to keep in mind, and also keep that in mind as we go over Chapter 18. And in the introduction, the author gives us some very good information that's been a recurring theme in this course, right? Which is the percentage of healthcare spending on the gross domestic product. So the author here has 17%, and that number is somewhere between 19 and 20% today. Now, when this book was published, or they're using numbers from 2010, which was the numbers that the administration used, the Obama administration used when they crafted the Patient Protection and Accountable Care Act, also known as the ACA. We went from about 50 million down to about 25 million people that were uninsured. And as a result of that, we did see some shrinkage of the gross domestic product, or excuse me, yes, the gross domestic product. But because of the constant challenges and litigation, the stripping of the individual mandate, That number has started to creep back up to about 50 million people and about 20% of the gross domestic product. For those of you that are not familiar with the gross domestic product, that is the total output of the United States, minus some actually pretty key indicators. But that aside, it is the measure that we use in this country and really around the world to measure spending in individual countries. So you can think of your total household income as the gross domestic product for your household. So if your household is making $250,000 right now, imagine if 20% of that was spent on medical bills. That would not be sustainable for your family, would it? And by extension, it certainly isn't sustainable for the United States. And so we look at really advances in technology, not just consumer behavior or consumers with acute or chronic conditions, but finance technology, medical technology, and healthcare policy all factor into that 20% of gross domestic product. You know, on some hands, you have policies such as, and we'll talk about it, value-based purchasing, pay per performance, bundle payments that are meant to lower cost and lower the percentage of GDP. But at the same time, you have new computer technology and a constant continuous delivery of medical technology that also puts upward pressure on pricing and upward pressure on costs. So something to kind of think about there. As we move on here and we're looking at issues facing the healthcare system, some of you may be familiar with something called the triple aim, where managers use the levers of cost, quality, and access in order to manipulate the levers of healthcare in order to either reduce price while increasing quality, or increasing access while maintaining quality and lowering price. There's something called the quadruple aim. Your textbook doesn't talk about it, but that fourth component would be satisfaction. And that satisfaction's coming from both the medical profession and the healthcare consumer. And so the author here talks about there's pressure to reduce costs, to improve quality for healthcare consumers. And it talks about how healthcare systems use this vertical collaboration as a way to integrate healthcare and control the costs through care coordination. So really, when we look at this vertical collaboration, we're really talking about accountable care organizations, and we're talking about patient-centered medical homes, where they look at the vertical patient flow. And for those of you that are unaware of that, that vertical flow starts with your relationship with your primary care provider. Then it goes to your specialist, then it goes to the hospital, perhaps some allied health professionals, if you will. But through this process of vertical collaboration, through ACOs, through patient-centered medical homes, and through other types of contractual agreements, health systems use these tools in order to help reduce price and reduce costs. So the pressure continues to mount the control of costs, to increase access, and to improve the quality of care delivered here in the United States. And so when we look at medical technologies under Section 18.21, medical technologies and services are constantly innovating in this country, whether it's a new pharmacological intervention, whether it's a new medical device, whether it's a new procedure. And I think we have this perception in the country that this constant innovation in medical technology leads to better outcomes, and it makes the United States health system the best health system in the world. But the truth is that the research doesn't bear that out. If you look at health outcomes in the United States compared to the rest of the quote unquote industrialized countries or the modern countries, at best, in most indicators, the United States is middle of the pack. And in a lot of those cases, we're actually at the bottom of the pack. And I'm saying all of that to say these are economic decisions and economic considerations that you have to consider in your dissertations and in your analysis. Medical innovation, medical technology innovation does not necessarily lead to better health outcomes. The research has certainly bared that out over the past 20 years. So, unlike other industries, I'm at the bottom of that first paragraph, unlike other industries, which the adoption of new innovations typically reduce the per cost unit of the output, many of these innovations in the healthcare industry usually increase cost and increase costs of the output, but not necessarily increasing the quality outcome. So, very important to determine if the innovation is supplements an existing treatment, or is a partial substitute for an existing, or is the innovation a result of a higher or lower expectancy for the patient that's being treated. Remember, when we talk about the pressure on pricing in from an economic perspective, it's always going to be a factor of the next available substitute. Give you a perfect example of that. Most of the country here out west, we're in a heat wave right now, 115 degrees. And so let's say if we wanted a nice cool soda pop, if you will, to cool off, and that soda pop is $2 per can. Are there any substitutes? Can we get juice? Can we get water? Can we get coconut water? Those substitutes and the availability and the cost of those substitutes will directly affect how much that ice cold can of soda pop will cost, if you will. That certainly isn't any different when we talk about healthcare spending, okay? So, kind of in conclusion, there, as I'm on that second, was that the third paragraph there, it's important to examine patients that are being treated with the new technology. Is it generalizable to the broader population? Does the new technology allow new populations to be diagnosed? Does it extend the existing treatment uh, outcomes for existing patients? Does it reduce the utilization by improving screening and diagnostics? And it's often difficult to determine that, especially in large health systems, because you have multiple initiatives and multiple changes happening all at the same time. You're learning through your dissertation process, and economists already know that in order to measure change, you have to isolate all of the variables and then just measure that specific change. Well, we don't have the luxury to do that in the healthcare industry, especially in large health systems. You certainly have the luxury to do that in your dissertation, and that'll be part of the expectation that you do isolate your variables in order to measure the independent variable, for example, that you're looking to measure. And then finally, economic tools are certain are certainly appropriate and applicable for micro level, and they also make valuable contributions at the micro level as well. So, and that's what economists do. We look at the change at the micro level. In this case, we can call that at the point of service between the practitioner and the patient, and we look at it at the macro level as well. In this case, we'll call that policies and procedures at the health system level. As far as computer technology goes, probably electronic health records are the most pervasive computer technology that we've seen in the space here within the last 15 to 20 years. We also have health information exchanges. This is where the information from the EHR can be transmitted over to a health information exchange that's housed by some type of regional health information organization. And when your PCP or specialists need to access that information, instead of having to perform those tests again or wait for a 1970 fax to come in from your provider or from your specialist, through the EHR and through this process called interoperability, your health records from the EHR and from the HIE, Health Information Exchange, should be interoperable and fully transmitted throughout these health systems. The technology is there and it has been there for quite some time, but there's really no willingness right now to kind of connect the dots. I fashion it to the Intercontinental Railroad that was built hundreds of years ago, well over 100 years ago now, and you had a crew starting on the West Coast and you had a crew on the East Coast. They laid railroad track all across the country. And at some point, they met in the middle of the country and they had to connect the tracks. And as a result of that, we had the first transcontinental railroad connecting the East and the West here in the United States. Well, we have that right now when it comes to interoperability of healthcare information. We just need the desire to connect those tracks together and have that information be seamlessly transmitted from your PCP, from your specialist, to the hospital, to the laboratory, to the rehab facilities, if you will. When it comes to hospital contributions here in 18.2, we talk a little bit about how the Accountable Care Act really has facilitated consolidation in not only hospitals, but also health systems, this idea called vertical integration. And we talked about that a little bit in our live session when we talked about United Health Group and how they are starting to vertically integrate now by acquiring companies like Change Healthcare, by acquiring payer side activities, by acquiring pharmaceutical activities. So they have a vertical integration. And so what that vertical integration does is it helps create economies of scale or economies of scope. And when we look at economies of scale, at least traditionally in economics, that means that you are the low cost provider because you can spread that cost out across so many patients. In this case, we'll say hundreds of thousands, if not millions of lives now that United Health is responsible for through these acquisitions, that perhaps they can spread those costs out and begin to reduce the organizational costs in their health systems. Not always easy to do in healthcare, right? Because of that third party payer dynamic that we've talked about extensively. kind of moving on here. So when we talk about mergers and acquisitions, to really be successful, according to your author, and I 100% agree, is there has to be some type of cultural similarities between the organizations. If it isn't affixed culturally, the merger and acquisition does not work. And ironically, we've actually seen several mergers and acquisitions be called off here in recent years. Because after the acquisition was announced or the merger was announced, there's this cooling off period of maybe 12 to 18 months where executives have a feeling out process. And at some point, there just may not be a cultural mix to it. And so these parties have to go back their separate ways. I think we saw a recent example of that with Hoag Hospital out there in Orange County, California, and how they moved away from their potential merger with Providence because it wasn't a good cultural fit. So, and actually, and that isn't anything that's unique to healthcare. It probably is a little bit overblown in healthcare because all of this is new to healthcare. But I was in the tech industry back in the '90s when HP and Compaq merged together in order to fight off Dell Technology. And the head of HP at that time, a lady named Carly Fiorina, who some of you may be very familiar with. She actually ran for governor of California among her many accomplishments there. And she took a lot of heat for that merger, right? But at the same time, without that merger, both Compaq or HP might not have been in business anymore. But ultimately, she took a lot of heat for that because it wasn't a cultural mix. It wasn't a good fit culturally. But I don't want to digress there. I think the main thing here that the authors want you to take away from this chapter, especially as it results to hospital and health systems mergers, is it has to be patient focused. And I'm in that paragraph there that says, as the healthcare industry turns its focus to patient-centered care, for that patient-centered system to function in a truly efficient and effective manner, you have to have a good organizational mix. You have to have a strong culture, and your processes and procedures have to be aligned to support the patient. The patient has to be the center of your care delivery universe in order for you to really have a truly efficient care delivery process, one that not only improves quality of the health outcome, it increases the access by and also reducing internal cost. So, as a result of these constant mergers and acquisitions that we've seen in the healthcare space over the past, I'd say, 10 years, maybe even 15 years now, hospitals that were traditionally nonprofit or not for profit hospitals are really starting to align themselves with for profit goals and objectives of the companies and corporations that have acquired them. And so even though they technically may still have a nonprofit or a not-for-profit status, you'll see GAAP accounting, you'll see accrual accounting, you'll see P&L statements at the division level, and you'll see a lot more of business metrics and business economic decision making now in the healthcare space. And I actually think that's a good thing. One of the reasons why when I got my master's degree, I decided to get an MBA in health services compared to getting an MHA. And there's nothing wrong with getting an MHA, by the way, but I just happen to believe and still believe that healthcare needs a healthy dose of business logic in order to really modernize the industry. Part of, the healthcare industry is that third-party payer system. And even though we like to think that we have a private payer system, an employer-based system, the truth is that 60 cents of every dollar that's spent on healthcare is spent by the federal government. And as a result of that, that means that really the healthcare industry is heavily subsidized by the federal government. And as a result of that, we don't necessarily get that true market equilibrium in healthcare like we do with every other industry. So I'm in that last paragraph here of 18.2. I'm going to go ahead and read that verbatim. The coordination of patient information across previously separated boundaries should decrease the duplication of services needed to perform repeated tests and procedures to obtain needed information. As the medical records of patients with multiple providers are centralized and shared, patient outcomes should improve and costs should decrease. And the key words there are should, because again, we haven't seen that yet. Research hasn't bared that out. Now, I don't have to tell you that. You're the ones that are doing the research every day, and you're finding that in your research findings. However, I do believe that because of the consolidation, we will at some point start to see uh, reduce costs and more efficiency. I don't know that that's going to lead to better outcomes because we already see that insurance companies and that doctors and executives that work for insurance companies or have contractual agreements with insurance companies, they are mandated and almost bound to make decisions based on the policies and procedures of these companies that don't necessarily always speak directly to health outcomes. And so we'll just have to see. Moving on to 18.3, when we talk about financial mechanisms, here in that middle of the first paragraph where it says historically, the healthcare system has been a production-based system, receiving compensation for services produced. And how insurance companies, they simply pass on increased costs to either employers that they have contractual agreements with or to the government that is one of the primary payers in the industry. And so insurance companies or this third party payer, they're really insulated from a lot of these natural dynamics that should take place in fully matured markets because it's so easy for them to pass the price on to either employers, to consumers through co-insurance or higher deductibles or higher co-pays, or directly to the federal government that again is a huge subsidizer of these types of services. When we talk about pay per performance, like 18.3.1, that pay per performance model was really created to incentivize and explicitly link incentives to quality and performance. Outside of the pay performance environment, providers were really just reimbursed for the activity and it had no connection with the outcome. But under a pay performance model, the consideration now is focused on improving the outcome and achieving some type of recognized threshold of quality, access, or both. When we talk about bundled payments, and bundled payments can be known as many different things. Sometimes they're called global payments, package pricing, episode-based payments, comprehensive care payments, or evidence-based case rates. But whatever we want to call it, Ultimately, these are adjusted for the severity and complexity of the patient's condition. It discourages the provision of unnecessary care. It encourages the coordination of care across a continuum of providers and health systems. And so ultimately, according to the authors in the bottom of that first paragraph, the goal of bundle payments is to reduce fragmentation of care, thereby improving quality and reducing cost. Of course, we see bundle payments in ACOs and patient-centered medical homes where providers across this vertically integrated relationship, PCP, specialist, hospital, allied health professional. The payer says, here's your bundle for treating a certain number of lives. And if you can, and for that payment then is spread all across the players in that ACO. And so, depending on the contractual agreement, perhaps maybe the hospital gets 50% of the bundle payment. And and so maybe the PCP gets 15%, the specialty gets another 15%, allied health professionals get 10%, and then maybe 10% is reinvested back in the ACO to improve quality programs, if you will. There's no specific way that these contracts are negotiated. So each ACO, each patient-centered medical home, each contractual agreement will have their own allocation or distribution of that bundle payment. And so the target price reflects the total amount that will be paid for the episode of care, and all the providers involved in the provisioning of that service is included under that price. So currently, an episode is typically defined as a specific period of time, anywhere from, let's say, 30 to 90 days after discharge from an acute care facility or after the first visit to a provider for a specific condition. There are concerns about bundle payments and if they incentivize providers to underutilize services, and that certainly isn't new. And again, kind of a recurring theme there, because as more providers and executives are aligned with now integrated systems or coordinated systems, there are policies and procedures that these people have to follow. And these policies and procedures aren't necessarily, or they are geared towards reducing cost and building efficiency within the healthcare model. We just don't know if they will improve health outcomes. The jury is still out on that, if you will. Under 18.33, we're talking about value-based purchasing. VBP is really to improve the care coordination and redesign the processes of care to produce high quality and efficient care delivery. So it's a move away from paying providers based solely on volume. And it generates a shared savings that can be split between the payer and the provider. So for those of you that are in the Medicaid and Medicare environment, think of that shared savings program. Think about the MIPS program. How it initially worked is, and I was with Healthcare Partners, which is now part of Optum, but Healthcare Partners was one of the earlier ambulatory organizations that signed up for the first round of CMS shared savings. And so what CMS did is they said, here are 500,000 lives, and between year 1 and year 3, let's say it costs $10 million per year to treat these patients. And so these patients are yours for the next 3 years. And however much money you are able to save by treating this panel of patients, assuming now that you've hit specific quality metrics and quality indicators, the amount of savings can be split up to 50% with the payer. So if you've saved $20 million over the 3 years that you've had those lives, and you've hit all of the quality measures, then you can expect 50% of that to be reimbursed back into your ACO as a shared savings compensation there. So again, it promotes effective resource utilization. It establishes clinical measures. It incentivizes providers to foster joint clinical and financial responsibility. It is a demand side strategy, right? Very important to understand that. And so it enhances revenue through differential payments, and it also increases market share as well. So the key components of this model is the patient-centeredness. And that's very important here, that patient-centered care. Now, finally here, when we talk about 18.4 and we talk about consumer engagement, there's a real good study there that your author cites regarding the Robert Woods Foundation and how it's important for consumers to understand the actual risk and conditions, to understand how to make informed treatment, understand the difference between good care and bad care, advocate for public reporting. But I don't want you to be fooled here. Ultimately, patient behavior and patients' habits and patients' cultural practice leads to acute conditions, chronic conditions, whether they be obesity, high blood pressure, congestive heart failure, you name it. Most of these conditions are cultural conditions, meaning that when our lifestyle, or when our form of life, Western life, if you will, when we import that into countries and regions that didn't have access to our way of life before, guess what happens within 5 or 10 years? They start to experience the same acute and chronic conditions that we have experienced here in America and in the West for hundreds of years. So don't be fooled. Patient and consumer activities will have to happen in their individual households, with their healthier diets, with their healthier lifestyles, with practicing preventive medicine. All of this stuff that we're talking about here from a healthcare perspective can only go so far. At some point, patients have to change their behaviors and live healthier lifestyles and have healthier habits. And they may not be able to do that on their own. They may indeed need help from municipalities and government officials. For example, and I'm not necessarily advocating this, but I know that in New York, for example, they put a premium on 2-liter sodas. And I know that a lot of cities have put tax or extra tax on cigarettes. And from an economic perspective, for every tax increase or for every increase in the cost of something, that decreases the amount of consumers that will use it. That's just a basic economic principle. Let me give you an example. Let's say cigarettes are $5 a pack, and you have 50 million people that will buy cigarettes at $5 a pack. Well, if you add a 10% tax and now those cigarettes are $5.50, you'll no longer have 50 million people buying packs of cigarettes. Maybe you'll have 47 million, because 3 million of the 3 million, maybe 1.5 million will say, I'm just done with cigarettes now because I can't afford to smoke them anymore. And maybe the other 1.5 million, will say, well, I would love to still smoke cigarettes, but I just can't afford them anymore. Or is there another substitute, right? Do they now move to another form of consumption? And so then that's where we really start having fun with the conversation as economists, when we look to remember how people make decisions that are in their own best interest. And part of their decision-making process does have to do with cost and availability of the primary items, and also substitutes of those primary items. Yeah, I think that's it here. So finally, in conclusion here, 18.5, and I'm towards the bottom of that first paragraph where it says that, the majority of these changes and decisions that are happening in the healthcare industry, and how the population of people that are 65 and older are expected to grow between 90% between now and 2030, and how legislation and regulation at both the state and federal levels are designed to kind of combat some of that. And we see that now with policies and procedures that are coming out from CMS. Again, we're starting to see a lot of mergers and acquisitions within the healthcare space. These healthcare executives are starting to align their healthcare systems with the realities of an aging population, with the realities of increased pressure because of medical technologies and computer technologies. So, and of course, with the sobering knowledge that right now, 20% of GDP on healthcare spending certainly isn't sustainable for anyone in this society. So we'll kind of see where we are. In the meantime, please consider all of these factors and all of these dynamics that we've talked about here. They do need to be reflective in your dissertations, and how your recommendations or how your suggested interventions will ultimately have economic ramifications for the programs, policies, procedures, or health systems that you are researching. Thank you very much. Please reach out to me with any questions, comments, or concerns, and I look forward to connecting with you in our live session on the 28th of this month. Thank you.